Hi, everyone. I want to explain my approach to lipedema reduction surgery. And I call it lipedema reduction surgery, not liposuction. In the US, liposuction is only coded as a cosmetic procedure. And so I want to make the distinction that this is a reconstructive for improving function surgery. And so I prefer calling it lipedema reduction surgery. I divide it in 6 parts: mapping the venous and lymphatic structures, marking the surgical area, administering tumescence, suction, aspiration, manual extraction of fibrous lipedema nodules, and then donning of compression. So we map the venous and lymphatic structures with a high-frequency ultrasound, looking for the saphenous and small saphenous, and then the lymphatic structures are going to lie medial or lateral to that they run the course. I'll show you that in another slide. Why do we do this? Dr. Herbst and I have reported on a series of lymphatic injuries that occur after liposuction in women with lipedema. This is a case that we reported on, a lady with lipedema who underwent liposuction and developed lymphedema in her right lower leg. And this is the lymphocinogram that we ordered, and you know, we don't know the rate of this. That occurred. It's rare, probably, but when it does occur, it's devastating. So I feel better taking these precautionary measures, mapping, and taking extra care in those areas where the lymphatics run. These lymphatics have been well mapped. This is Shinikoa's mapping. We also sometimes do ICG mapping as well. But as you can see, the principal lymphatics run in the leg, close to, sometimes in, and then parallel to the greater and small saphenous in the front and back, as you can see here. We mark and prep the patient. We do give oral sedation when with 2 milligrams of lorazepam and 2 milligrams of oral Dilaudid, and then use betadine chloroprep solution to sterilize them. I use Tumescent anesthesia. I was trained by Dr. Klein. I follow my mentor and still use his techniques. I use his pumps and Monty tip cannulas. I believe in generous tumescence, and feel like that is also protective of lymphatics. I use a micro-air liposculptor for suctioning with a 3 millimeter multi-hole cannula. I occasionally will use a double Mercedes 4 millimeter on my larger patients, but that's as big as I do. So some patients we do the legs in 3 surgeries. Some we do it in 2. So smaller patients we're able to divide and do the legs in just 2 surgeries: the lateral, outer, the way most surgeons in Europe do, and then the inner as the second. But for our larger lasers, we divide it into 3, and these are large volume liposuctions. The average volume is around is over 5 liters removed. And then we do pair them with the, so for example, the lateral thighs we do with the buttocks when we do that way. So after we have done our suction, we feel for fibrous lipedema nodules, and those that remain we sort of milk along the long axis and loosen them up, and then either remove them through the adducts, or we have to make a another incision to get the lipedema nodules out. And then after the surgery, the patients walk on their own power to, use the bathroom, and then we put them in compression. So we leave the adducts open, and then we then wear medical grade compression, and then we follow them up either the next day or 2 days later. Well, so now I'm going to get into the actual video of the surgery. Thank you for your time. I'm gonna and we're gonna show you the actual surgery. So before surgery, we mark the venous and lymphatic structures in the leg. So I've made just scanned and made some blue dots for where the saphenous, the greater saphenous runs along there. Now, the lymphatics channels that have been well described, and they run parallel to the greater saphenous and the smaller saphenous. And so we first, with the high frequency ultrasound, we map the saphenous, and then we find the major or principal lymphatic collectors. And so here, if you can, here, right there, that's the saphenous structure. Then I go long on that. And there's actually just to the side of it, there is a little lymphatic channel, and I'm marking that in, so that's going to be marked in green, and then the saphenous right here is going to be marked in blue. So I scan this to show these landmarks, so that we can take extra care in these sections to not transect. But I will also mark the saphenous up here, because we are going to be going up into the thigh, just around the knee, anterior medial lymphatic collecting duct, and a anterior collecting duct up the leg. And my extra care boundary lines along my lymphatic collecting ducts anteriorly, and then I'm going to we're going to turn her and do the same on the back of her leg around the small saphenous, because we're going to be doing it. We're going to be in the calf today. So I'm starting on this other leg, and first I start by marking the saphenous, and that always gives me a good pathway to find the major lymphatic collecting ducts. And I'm just we're marking the saphenous, the small saphenous, because we're working in the calves and ankles, as well as the lower part of the thigh. So now we're going to go. We see here the saphenous sheath, and if you can see right here, there's a lymphatic that's in the saphenous sheath here, and you can see the lumen of it. And if you look very closely, so you can, yeah. So yeah, and when we do courses, we can sometimes see flow in these lymphatics, and that's how we're sure it's a lymphatic and not another structure. We're on the other leg now, and we can see here with small saphenous sheath, and again there's a small lymphatic running in there, just medial to the small saphenous. So now we have the boundaries on the back of the leg where we see one a principal collecting duct on the lateral and medial to the small saphenous, and that's sort of my watershed area where I take extra care on the back of the leg. So we have a beautiful lymphatic channel here marked going longitudinally, and my expert sonographer Crystal has come through again today. So it's
dive here.
Yeah, so it's going lateral, and it is kind of it's just a little bit above the fascia, and then it's coming forcing diving a little more laterally, and so now we're connecting the dots here, and I'm just darkening in my line so that we have our boundaries, and then we're going to get her prepped for surgery. Yep. So I'm marking her for surgery here now, and this is our boundaries for our surgery. We're going to go back just a little bit around this knee complex, and then she has had some previous liposuction on her thigh, but not on her calf. And then I'm just marking our areas. We're going to go down. Get the ankle. It's a little fat lobule on the ankle. So we just have it going here,
okay,
and there, and we're gonna get this down here. Our markings are complete. So I'm starting with just making some adits. We use punch biopsy to place the adits, and I like to place my adits like my access points for the tumescent midway at the lower boundaries and upper boundaries. So basically, and then I'm just right now just a little punch hole. This is a 2 millimeter punch, and I put also some, and then medial to it, and so I can basically stay parallel along in these areas of concern. And then another added out here laterally. Now the patient is, the patient has had some oral sedation, but is awake. So I'm just starting the tumescing here on this leg here, and we follow the Klein Tumescent anesthesia protocols. These are this is a Klein pump over there, then this is these are Monty tip Klein cannulas, and just more tumescing. You okay, Vicky? So you can see the tissue is blanching as the tumescent starts to take effect, as well as swelling. You can see the tissue blanch and get a little bit of code orange, and then it turns, and then it gets completely swollen and tumesced. So I'm raising a wheel right here, just, getting ready to do my adit. So I'm just finishing up the tumescing, and we're just going to touch it up. There's still a little area here that isn't fully blanched around the knee complex, and she's had previous, as you can see, she's had previous knee replacements, and so it's a little touchy area. We want to make sure it's good and tumesced. So this is the micro-air liposculptor, and I want to thank Micro-Air for supporting some of my research. So we use this to help break up the tissue, and we find that we're able to get a little more of the lipedema tissue out with the liposculptor. As you can see, the cannula strokes are longitudinal. I'm following the markings of the lymphatics and staying clear of them, just going longitudinal up the leg and getting a nice
nice, smooth. We're right in the plane. The perfect plane for this is the easiest plane. It's not too deep, not too superficial. Just go smoothly through the subcutaneous tissue. You can see here now it just goes very, I mean the vibration of the cannula is doing most of the work here, and I'm just gently moving it around so that at a pretty steady pace so that we get even even harvesting of the tissue. This lateral, there's a characteristic increase in the lateral calf here that we tend to get extra thickness through here, and so I want to get that reduced. So I'm just going over the knee complex here now from the mid calf, and as you know, ladies with lipedema, they tend to have the fat hangs over the knees, and now she's again staying longitudinal as I longitudinal to the collecting ducts. As you can see, I make a lot of adits, and I, like my mentor, Dr. Klein, I believe that, especially when you make these tiny adits that really heal with almost no scar, that the number of adits allows you to each time to extract the tissue with putting the minimal stress on the structures around it. So so I'm able to more evenly and completely extract the tissue because I have adits or access points at each angle. And as you're going to see, we're going to do multiple positions through this to ensure we get as much tissue as possible. And you can see I'm over the marked areas, my watershed area of caution, but I still maintaining the longitudinal orientation of the cannula, and just in the plane that's not too deep and not too superficial, just easy like butter. So I am now just doing the other leg here, and again, we're going just parallel to the lymphatic collectors on this lower leg, and it's just very, again, in the smooth plane, very gently. The vibration is really, the micro air power assisted handpiece is really doing most of the work. I'm just very gently going along the course of this tissue. Through the course of the surgery, the patient is changed through, moved and adjusted through 6 different positions, and so that we can get each little quadrant of the leg in the longitudinal position through the various positionings. So you can see here, now we have my landmarks for the small saphenous on the back here. Even though I'm just on the lateral projection right now, you can still see that, as you know, the small saphenous goes out laterally towards the ankle. Yes. Now we're on our side, but we're slightly turned towards the stomach. So just gets this one more little angle to get all the lipedema tissue I can.